Okay, two patients we definitely need to talk about before we finish this. The one patient, the 36-year-old smoker. What are we doing with her? Would you start her on a birth control pill?
So I don't know that I would start with a birth control pill, but if that's what they want, then I would go to the ones that have the lower VTE risk, which is our estradiol-containing OCP. So there are choices, but I think we get so fixed in like, oh, you can't have this, and to get away from that kind of frame of mind and just offer patients choices. But I would definitely start by recommending something that does not contain estrogen.
So I think the full extent of my practice is in perimenopause at this moment. So that's a very classic patient. And there's two other options that are newer, much like the Nexaplon. And as I mentioned, Nextstellis, we suspect, contraindications are contraindications. You can't be fancy free. It's funny, the smoking actually look up the smoking guidelines because it's not so black and white. You have to take the patient contextually. And yes, she needs contraception and she deserves it if she can take it. But I really use Nextstellis quite often, right? Because of the novel estrogen, and it works just really well. Has been a game changer. And that would be a patient that I'd talk about an implant to too. Perfect candidate that way. Having said that, sometimes I think there's the assumption that progesterone does not have thromboembolic potential. It does, right? So you still have to provide the counseling. And the other clinical pro, I'm just on the throes of coming back from the Canadian Menopause Society conference. Contraindications to birth control are different than for menopause hormonal therapy. Another talk for another day, but that was a bit of a clinical pearl that came out. A lot of people asked me those questions during the sessions. So